Okay, introducing Dr. Lindsey Paulson, who you guys were hearing, but I don't know if the rest of the attendees on Zoom were hearing, is a graduate of 2007 School of Medicine here and knew the founder of MiniMed, J.J. Cohen. So that was a little chat that we were having. Dr. Lindsey Paulson is a staff physician at Wray Community District Hospital and Clinic and has been able to fulfill her lifelong dream of practicing full spectrum family medicine, including obstetrics, pediatrics, inpatient, outpatient, and emergency medicine. She is faculty at the NCFM Wray Rural Training Track, as well as the CU Department of Family Medicine, where she serves as a preceptor for the Integrated Longitudinal Clerkship. She is trained in surgical obstetrics and is passionate about providing safe, high-quality pregnancy care in rural Colorado. Prior to moving to Wray, Lindsey completed her residency at North Colorado Family Medicine in Greeley, where she was administrative chief resident. Outside of work, Dr. Paulson enjoys spending time with her husband and 3 children, traveling, reading, and is deeply involved in the Wray and Colorado communities. She serves on the board of trustees of the Veteran Foundation and is a Wray Eagles superfan. She can be found on any given day on the sidelines at flag football practice, sharing stories with her elderly neighbors, mentoring residents and medical students, or wearing her purple Converse sneakers and screaming her heart out for the Wray Eagles. That's just awesome. That's so awesome. So what we're going to do, Dr. Paulson, before I give it away to you, is we're going to have about a 50-minute session where you present your content, and then we'll be fielding questions both from Zoom and potentially from our live audience. Does that sound okay?
Perfect.
Great. Ladies and gentlemen, I give you Lindsey Paulson.
Hello, everyone. Gosh, I'm so honored to have been asked to share about what I love to do, which is practice medicine and really more correctly, the frontier county of Yuma, specifically Wray, Colorado. So here we go. So all these happy cow photos that you see today are thanks to my friend, neighbor, Jody Buck, who has a cattle ranch at the state line, Nebraska-Colorado state line. Ooh, okay, there we go. Okay, so today, what we're going to be learning first is I want to talk about the important difference between Colorado's urban, rural, and frontier counties, because there is a differentiation that's significant. Second, we're going to understand the economic and social challenges in Colorado's rural and frontier counties. We're going to go on a tour of some of Colorado's rural and frontier counties. I'm a strong rural advocate, and there's a lot of different communities that I love. And this will kind of showcase some of the differences socially, economically, in the different Colorado regions. Understand the challenges to obtaining obstetric care and delivery services in rural and frontier Colorado, and hear success stories of obstetrical challenges and successes from one of Colorado's frontier obstetrical hospitals, which is here in Wray. And then finally, I'm an avid reader and I have some region-specific book recommendations. I love sharing books with people, and so I'm excited to share these with you. So here is a map of Colorado with the urban, rural, and frontier counties differentiated. So urban county is a county within a metropolitan area where there's a population of 200,000 people or more. And so obviously we know what our urban counties are. And then over here on the western slope, we have Mesa County, but this is basically Front Range. Rural county is fewer than 500 people per square mile. And so here we have these light blue counties, which are our rural counties. And then finally, we have our frontier counties, which is fewer than 6 people per square mile. And it's just kind of interesting looking at this map. So this is the majority of the Eastern Plains. And then we have some of our mountain region here. Phillips County, I think, is highlighted as being rural because it's a smaller county and has 2 cities, Holyoke and Haxton, but really it has the sort of frontier feel. And then Gunnison has a larger city, Gunnison County, and we'll talk a little bit more about that later. but it is technically a frontier county based on the large size, but Gunnison, the town of Gunnison itself has more of a rural size. So that's just an interesting observation I had looking at this map. And so frontier, fewer than people, 6 people per square mile, or more cows than people. So here's some of our happy Yuma County cows. So first we're going to go on a rural Colorado tour. And I think this is important. So this here is a photo of Pedro. And Pedro worked on my great grandfather's farm in the San Luis Valley. And over here, not in the picture, would be where my grandmother grew up, and then just a quarter of a mile to the I guess it would be south of that is where I grew up. And this is in the days where Pedro had to use these siphon tubes to water the potatoes, is what's growing in this field here. This was before the center pivot sprinklers started. And it's important to know because Pedro and his descendants still live in the San Luis Valley. And I think it just showcases the cultural complexities of this region, and that then contributes to the difficulties and challenges, I guess, that we have in providing all medical care, but specifically obstetrical care as well. So why is our rural Colorado tour important? So I love Colorado, especially rural Colorado, and I think it's one of the most diverse states in our nation, geographically, socially, economically. And understanding the challenges our rural communities face is the basis for providing culture-centered care to the people who live and work in these places. And Colorado's rural communities, rural and frontier communities, are made up of hardworking, creative, and determined people. And so we'll get to meet some of the people in these counties. I just love these people. And I think it's really important that you learn some of their stories, because it helps kind of me share my passion with you about why it's important to take care of all of these beautiful people that live in our rural areas. So this is our team in Wray, and this is kind of my my why, which is thriving Colorado communities start with thriving Colorado families, which begins with safe and accessible pregnancy care. So here we have the cool thing here is all of these people here are, we have a student here. This is Ryan. He graduated from med school just this last May. We have Ashlyn. She's getting ready to graduate. They were both our longitudinal students. This is Dr. Shaw. She was one of our resident doctors and also a CU graduate. Dr. Kaza was one of our residency graduates. And then Dr. Reed, he was the second resident ever in Wray and has made his home in Wray. And Dr. Criley also was one of our graduates. So is Dr. Bear. Dr. Bear was one of our medical students that we just loved. And so everyone here has trained with us and kind of shares this vision and this mission. It's the secret sauce, really. So here's our map. And these yellow stars are all of the places where you can deliver a baby in a rural and frontier county. And this is Dr. Deutschman helped me put this together. And so you can see, and we'll talk about this a little bit more, but I just want you to look at this map and then keep this in mind as we proceed through the talk, and especially in the rural Colorado tour that's coming up next. So the first rural Colorado highlight is San Luis Valley, which is where I grew up. It is the world's largest alpine valley. Includes Castilla, Saguache, Alamosa, Rio Grande, and Conejos counties. And the main industries here are agriculture, specifically potatoes, and tourism as well. And we'll talk a little bit more about the progression and changes in agriculture. So here is a little picture of the valley floor from my dad's airplane flying in. I always love whenever I get to fly home, he'll come and pick me up sometimes, and getting to see my home from the air is always really special. Here's another, of course, many of you are probably familiar with the sand dunes. This was a beautiful fall day, again, from Dad's airplane. And then here we are. This is my brother, and this is me. And this picture is important because, well, I just think growing up in the San Luis Valley, it just shows how important agriculture was to us. But we're in a barley field Coors barley used to be one of the major crops in the San Luis Valley. And in the most recent years, we have transitioned away from barley because it is not really cost effective. And it also, from a water standpoint, was challenging. People were trying to be judicious with water use. And so changing their crops to crops that require less water has been important. And barley was used initially as a rotation crop because that returned the nitrogen to the soil that the potatoes will need. And they've changed the crop to a number of different things, specifically something called green manure, which is a mixture of grasses that requires very little water. And this is my family walking by the Rio Grande River here. Water is really central to this region, as it is to all of our regions in Colorado. But I think that the important thing to know is that the people here that live in the San Luis Valley are really trying to be good stewards of their water resources. And I think that is one of the important social and economic things that we need to know. It's ever present in the lives of people, their water concerns. So here is probably in that same field that my brother and I were, based on this mountain behind here, my dad and my daughter, when she was little, digging their potatoes. So this is the main crop that we have in the San Luis Valley. And then here we are with our bags of potatoes ready to go to the stores when we went on a tour here. This is my San Luis Valley specific book recommendation, Sabrina and Karina, which is a book of beautiful short stories about specifically women and their challenges. And the setting is San Luis Valley and then also Denver. It's really interesting. So check that one out. Okay, Colorado highlight number 2, which I love this area. There's some really interesting things going on here. This is Craig, Colorado. Craig is the county seat of Moffat County, population 9,000. Main industries here are energy, which coal mining, and agriculture, specifically ranching. So Craig is a really interesting place and also super important to know about as it relates to the social determinants of health that we talk about. Here I am visiting the Trapper Mine, which is just to the west of the town of Craig. And the state of Colorado has pledged to transition to clean energy, 100% clean energy by 2030. And so the Trapper Mine is in the process of transitioning out of coal. The interesting and very important thing to know about this is that the Trapper Mine supplies 50% of the tax revenue in the region through their property taxes. So schools, all of the fire department, ambulance, everything, they are 50% funded by this Trapper Mine. And so in the transition away from coal to clean energy, this is really something that's going to affect the financial health of the county. And it's important that obviously that's going to affect the physical, specifically mental health of the people that live here. This is a group of people. So here we have Wade Buchanan. He works in the governor's office of just transition. And the job really of the office of just transition is to aid the transition in these areas away from coal to clean energy, and make sure that the communities continue to have a thriving economic atmosphere. And then here we have 2 people here. This gentleman is the city manager of the town of Hayden, which is again to the west of Craig. And this is Jennifer Holloway. She is the chamber director in Craig. And they're just doing so many intentional, insightful, and creative things to ensure the economic viability of the town of Craig and the entire region, really, and Hayden, obviously. So this is a podcast that we did at the Betcher Foundation, Colorado Leadership Stories, and this Colorado's coal transition. It really talks about a lot of the different challenges that they have and then some of the things that they're doing to ease that transition. So that's an interesting podcast if you'd like to check that out. This is another really fascinating podcast. It's 8-series podcast about the coal transition. And it just brings up so many interesting things that I had no idea. I learned so much listening to this podcast. And so I think that that's another worth a listen. This is Kirsten McPherson, she also works in the Office of Just Transition, and she has this wine bar gift shop. She's opened a wine bar in Meeker, and she's just a go-getter. And I think I bring this up because two things. Number one, she came to me at a meeting once and said, how do we get a place for women to deliver babies in Craig, because they don't have an obstetrical service in Craig, and they have to travel to Steamboat. And so that's a major challenge for people that live in that region. And then secondarily, she works in the, I think I already said she works in the Office of Just Transition, but she's a very creative economic force in this region, doing a lot of things to try to ensure economic viability when the mines are closed. And this is another gal. Her husband worked in the mine, and then now they opened this fiberworks business. They have sheep, shear their own wool, make their own yarn. And it's just, I think, another great example of the creativity that people have in these rural communities and just perseverance. This book was just a really gorgeous book called The Meadow. It takes place not quite in Craig, a little bit to the east of that. But again, another one that's one of my favorites. Great Colorado book, worth a read. And I have created a document, and I emailed it to the organizers so they can share this reading list with you via email, I hope. So you don't have to scribble all this down. Okay, number 3, we have Gunnison, Colorado, which is one of my favorite places on earth. Gunnison County is generally accepted to have the coldest wintertime temperatures in all of Colorado. Home to the mountain town of Crested Butte, one of my favorite places. Also Western State University, and population of 17,000. Main industries are tourism and education. This is maybe not in Gunnison County, but this is one of the favorite things to do in Gunnison and Crested Butte. This is my brother in his downhill mountain bike racing days. So that's a big industry in Gunnison, Crested Butte area. This is my daughter and I at the Continental Divide on Monarch Crest Gondola that has recently been sort of refurbished. The building there is under new ownership. And this was an interesting day that we had, because we rode the gondola up, and then there was a thunderstorm, so we got stuck. And so we had a really engaging conversation with the gentleman who is running the lift that day. And he was just talking to us about his housing challenges and how he works as a lift operator between the Monarch Crest and also at Monarch Ski Area, and he is unable to afford any housing in Salida just because of the real estate costs increasing. And this has been across rural Colorado and all of Colorado, really, but the housing costs in these mountain towns are just inaccessible for many of the people that work in the tourist industry. And so that's a major, really inadequate housing is one of the social determinants of health that we're interested in. And so obviously experiencing homelessness, especially in a freezing cold place like Monarch Crest or Salida, that's difficult. So just a picture of us hiking near Crested Butte. And then this picture is us at my husband and my daughter at our favorite pizza restaurant in Crested Butte. And also just kind of points out the difficulties that the people, especially in Crested Butte, but many of our rural resort towns have in in maintaining their businesses, the small businesses in these areas, because of the staffing shortage secondary to housing difficulties. And so they've done a lot of interesting things in Crested Butte to keep their Main Street thriving. And it's a super busy town and they're doing well, but there are so many challenges. And this was one of my favorite days ever. There's my Crested Butte specific book recommendation. It's called Go as a River by Shelley Reed. And it takes place in the town of Iola, Colorado, which is actually now at the bottom of Blue Mesa Reservoir. And it's just fascinating, just very well written book. Shelley was a professor at Western State University and now is on book tour. And I just happened to run into her. I went in the bookstore there in Crested Butte hoping to find a signed copy, and I found a signed copy and the author. So that was best day ever. So check that one out if you haven't read that one. Okay, and then our last Colorado highlight. Here we are, Yuma County, my current home, 2,369 miles. So I think it's roughly the size of, I think, Connecticut, maybe I've heard someone say, home to Wray Community District Hospital and Clinic. And the county seat is Wray, population 2,200. And the city of Yuma is also in Yuma County, population 3,500. Yuma County is home to 10,000 people and 260,000 cattle. So definitely more cattle than people here. And our main industry is agriculture, specifically farming and ranching. So here's some more happy Yuma cows. And this is more happy Yuma County cows with my kids. But the interesting thing is these cows belong to Dr. Lloyd, who was a surgeon at our hospital for 30 years. So if you live and work in a rural area, then you can be a surgeon and a cattle rancher. So that's fun for him. Here's some more pictures of my kids and my husband. I sent them to help Dr. Lloyd brand his cattle in the spring. And we love our cattle and we love our sports in Wray, Colorado. So here is our football team. This little gal here in the middle was my medical student, and one of the popular medical student activities to do here in Wray is to stand on the sidelines and patch up the guys with their football injuries. And then this next photo is kind of a bad blurry picture, but this is it's a still from a 9 News Sports clip that because this just shows the spirit of our community. So you can see all of these people, they're getting ready. I'll show you the next picture. So basically they're cheering, they're getting ready. They're watching this kid win the state championship in wrestling. And I love, oh no. I love looking at this picture because I can see up here, Dr. Lloyd, he's our, the surgeon. And then down here, these people are the grandparents of a wrestler who couldn't even wrestle that year because he was hurt. And then we have, the former chair of our hospital board and just the whole community coming together to cheer this kid on. And so there he is winning his, I think it was his 3rd state championship. So cool kid. He's wrestling in college now. And then, my Yuma County book. This book, written by Kent Harif. He's written a number of books that are also just gorgeous books. This takes place in thinly veiled Yuma, Colorado. Holt, Colorado is the name of the town. And also he has written another book called Our Souls at Night, which is also a next Netflix movie with Jane Fonda and Robert Redford. So you may know that movie. But this is a great Colorado book to check out if you haven't already. Okay, so on to the next section, which is Birth on Colorado's Frontier. So here's one of my families on there. They have a feedlot and also bison ranch, and these are 3 of my babies. So here's our map again. And so just to review, so we visited Moffat County, which for obstetric services, this is their option. And, I know Utah's right here. Really isn't anything close. So their option is Steamboat. San Luis Valley, this huge area here, their option is Alamosa, and even people who live in Mineral County have to drive into Alamosa. It's an hour over mountain passes. And then, people in Saguache may go to Salida, they may go to Alamosa. It's kind of equidistant, just depending on where they live in the county. Up in this area, of course, they would go to Gunnison. And then let's see, Gunnison, they're going to have people coming from all over. Lake City and let's see, probably in between here, getting from Mineral County to Gunnison, Mineral County to Alamosa, the people that live here, that's a scary place to be pregnant. And then, here we are in Yuma County, and we take people from Sedgwick, Phillips, Washington, some Morgan, certainly Kit Carson, and now Cheyenne County, because Burlington Hospital, which would be right here, recently stopped delivering babies. So people are traveling from Cheyenne Wells. We also take people from Nebraska Imperial, which would be north of Sedgwick, and St. Francis, Kansas, which would be east here, almost directly east, a little bit south of Wray. And so this is my little soapbox that I climb on for anyone who would listen. So this is eastern Colorado. So this represents essentially a third of our state. If you're pregnant and need to deliver a baby, your options are Fort Morgan, Brush, Sterling, Wray, La Junta, Lamar. Lamar was closed. There was some issues in the pandemic. Their obstetrical wing was closed. They have recently opened. It must be just very recently, because so I added that star back. But as you can see, this is what we would call a maternity care desert in here. Lincoln County, Hugo Hospital used to deliver babies. Now that's closed. Many people from Lincoln County can make it to Colorado Springs. That would probably be their preferred. But it's kind of scary on the interstate, trying to get where you need to go from this area, and especially these counties. Okay, so I put these red arrows because if you want to go out of state, what your options are. So Sidney, Nebraska would be an option. The next closest thing here would be Colby, Kansas, which is actually 2.5 hours from Wray, I think, plus or minus. You can, if you live in this region, you can go to Garden City, Kansas, which is again a couple hours to the east. And then if you live in this region, you could go to Texas, which I think some people do. Maybe not for obstetrical care potentially, but especially some of the other specialty care that they may need. This is an article written by Dr. Deutschman and a number of his colleagues. And so basically what this talks about is that family medicine physicians are crucial in the provision of maternity care in our rural counties. And a number of studies have shown that family doctors provide safe care in these areas. And also Dr. Deutschman's argument here is that we need to make sure that family medicine residencies continue to train their residents, especially those who are going to rural areas, in order to provide maternity care. Okay, so we'll talk about a few different things that have happened in my practice. I have a lot of different stories, but I'm going to share a few with you. So this is Wray Community District Hospital. This is where I work, and there's a clinic that's attached just on the other side of this. We're a 15-bed critical access hospital. We have 3-bed emergency department, 2 operating rooms. We have 5 family physicians, 2 family medicine residents. They come from the North Colorado Family Medicine Residency in Greeley. We have an OB case management nurse. She's IB CLC certified lactation consultant, which is a really big deal. It takes at least 1,000 hours of work with patients and passing a big, really complicated test in order to get that certification. So that's a big deal. We have 24/7 anesthesia availability. We have 3 CRNAs, and then we do about 150 deliveries per year, including we have cesarean capabilities. My mantra that I tell the residents when we're training and the students, and I think this applies to pretty much everything in rural medicine, is to be cautious, but be brave. You can, if you're not cautious enough, patients can be injured. If you're not brave enough, patients can be injured. So that's something that I preach constantly to the residents. This is my great aunt. She was the director of nursing in Benkelman, Nebraska, rural county, just close to Wray, for 30 years. And she was definitely one of the most brave healthcare practitioners I've ever known. Okay, so our first case is the gymnast and her mother's VBAC. VBAC stands for vaginal birth after cesarean. I texted her mom to ask her if it was okay if I shared this story. It was really an emotional delivery for all of us. And she was just so excited that I was going to share this story with you all, because she was so grateful for how things went. And it was quite an adventure that we had together. And luckily everything went well. So mom was a 28-year-old G2P1. This means gravida 2, para 1, meaning she's had 2 pregnancies and 1 delivery. She's at 40 weeks gestation. 40 weeks is considered full term. She presented to the hospital. She had spontaneous rupture of membranes, meaning her water had broken at home. She was having a few contractions, and when I examined her cervix, she was 3 centimeters dilated. A woman needs to be 10 in order to deliver. 50% effaced, which means her cervix is thinned out about 50%. And -2 station basically just indicates the position of the baby's head in relation to mom's pelvis. So that -2 indicates that the baby's head is above the pelvic outlet. I started her on Pitocin augmentation because her contractions were irregular and there was concern for infection, given that she had her membranes had ruptured. Her labor progressed relatively normally, and then the nurses called me and said she was ready to push. I checked her and she was 8 centimeters, but I put my finger in the baby's mouth. It took me a minute to figure out what I was feeling. But I could feel the baby's mouth, nose, and chin on my exam. And the fetal heart tones were significant for deep variable decelerations, which I'll show you a picture of here shortly. And mom, she had the urge to push, so she tried to push a couple of times, but baby just wasn't tolerating that. So here is baby Tessa. This is kind of the position she was in. Her chin was a little bit more anterior. If you can believe it, the back of her head was actually touching her spine. So her forehead was up behind the pubic symphysis here, and her chin was actually the presenting part. This is a little snippet of a fetal monitoring strip that shows variable decelerations. So on the bottom is the contraction pattern, and on the top you can see she has the baby's heartbeat decreases during this contraction and then goes back up and then decreases again when she has a contraction here. This, sorry, keep doing that. Anyway, so this patient is pushing, as you can see from these little spikes here. So the patient, her husband, and I discussed our options. And given the baby that was having distress with contractions, we elected to proceed with a C-section. We were running back to the operating room, and I promised her that she could have a VBAC next time. So we'll talk about that next. So she was taken to the operating room. Spinal anesthesia was accomplished without difficulty. And we performed the C-section, and the baby was, in fact, I've never seen a baby in that position before, but she had a very flexible neck and a stiff neck for a couple months after. So Tessa, beautiful, smart, and very flexible 6-year-old girl. Her mom is really thankful that we were able to provide that care for her. So vaginal birth after cesarean is kind of a hot topic. It's rarely performed at critical access hospitals. In fact, I think we're probably the only one in the state of Colorado. Our risk management doesn't love that we do this, but we believe that it's the best for our patients. The reason is because there's a one risk of uterine rupture, which can be catastrophic. And in order to do this, you have to have anesthesia, OR crew, and your delivering physician all in the hospital during the patient's labor, which in a resource poor area like Wray, I mean, we have a fair amount of resources, but this can be somewhat difficult. I do believe that overall there's a decreased risk overall of morbidity related to multiple abdominal surgeries. And I've had a number of women do VBACs at our hospital, and like three VBACs. I've had several patients that do that, and that just saves them so much abdominal surgery. And also decreased recovery time. And the reason why we have this trouble is there was an ACOG position statement in 2004, which really has limited the number of VBAC deliveries based on that, immediate availability of the surgeon requirement. And so I've heard stories like, for example, in Salida, of women who wanted to have a VBAC delivery and didn't have a hospital close by that could accommodate that. And so they decided to have a home delivery. And the providers in Salida told me that they've had a few women come in who tried to do a VBAC at home, who've had ruptured uteruses at home, and it was, catastrophic. I think they've had a number of maternal fetal deaths from that. So Tessa's baby brother, Seth, was born via VBAC 2 years after his sister. And then they subsequently have another little girl named Jenny. And it's just a beautiful family. And it was a little bit of a venture getting everyone here, but we got everybody here safely. So this is one of my favorite days also. This is Dr. Waymura, my partner, mentor, friend, on a day that we delivered twins. So this is call all the doctors in town, because literally at one time there was just the three of us. So it took every doctor that we had in town to deliver twins. Just a quick overview on twins. So this type is the most common di-di twins, which you would know as fraternal twins. They can be male-male, female-female, or male-female. And these twins are considered the lowest risk of twins. This type of twins is kind of hard to see, but down the middle here is a thin membrane. These twins are, this is mono-di twins, which are higher risk than the di-di twins. And they will be the same sex. The feared complication with this is twin-to-twin transfusion, which is basically where blood vessels that are shared in the placenta will form such that one of the baby steals the nutrients and blood flow from the other baby. And so these babies, all twins, you need to monitor to make sure that they're growing at the same rate. But these twins, you have to be even more conscientious about their growth. And then mono twins, which are considered to be very high risk twins, they have a high risk of mortality, and these twins would be managed primarily by maternal fetal medicine specialist. Okay, so considerations for twin delivery in my hospital. So to be conservative, I only offer vaginal delivery for women whose twins are both head down. If baby A is head down and baby B is breech, we either offer a C-section or refer them to a tertiary care center for delivery. If baby B is smaller than baby A, but baby B is breech, we can do a breech extraction of baby B after baby A is out. I always do an ultrasound when the patient comes in labor, just to make sure which position the babies are in, because they can switch on you. And then ideally there's a doctor for mom and a doctor for each baby.
Dr. Paulson,
Yes.
just giving you about a 6-minute warning now.
Okay. I think we're going to make it. Thank you. Thank you. I like to have the ultrasound machine in the room to confirm the position of baby B after baby A has been delivered. And then I like to have the OR crew in house, very similar to the VBAC situation. And I always have everything prepared to care for a postpartum hemorrhage, just because of the increased size of the uterus, these moms are at higher risk of postpartum hemorrhage. Okay, and then I have 2 more cases, but I'll just do this one. We'll skip the last one so we have time for questions, but this is another one of my favorites. This was a quote from my perinatalogist that I consulted. Can we just send her a helicopter and a bucket of blood? So this was a 24-year-old G1P0 at 38 weeks gestation. She had transferred her care to Wray around 34 weeks from the health center in Fort Morgan. And then she came in labor, contractions every 3 to 5 minutes. When I examined her, she was 7 centimeters and 80% effaced. And then the lab tech came in and drew her blood. And then she came in 10 minutes later and drew her blood again. And we were all looking at each other, trying to, not alarm the patient, but the nurse whispered to me that the platelets were 27, which is markedly low. Normal here is greater than 120. So I called my perinatologist in PSL immediately, but because the delivery was imminent, we just planned to deliver in Wray and then transfer immediately after. The reason that I love this story is because it just displays how well our team in Wray worked together, all of this multidisciplinary team. And I think that's one of the great things about rural nurses and everyone who works in a rural hospital is that, they're kind of the jack of all trades. And so the lab director who was on, we were trying to figure out how to get as much blood as possible in case we needed to do massive transfusion, just because this patient had limited capability to clot based on the low platelets. And so we had 2 units of her type specific blood and then 2 units of O negative blood. And then we called the next hospital over in Yuma, and then the county sheriff rendezvoused with State Patrol to pass off 2 additional units of blood for her in case we needed them. And then one of my nurses suggested that we give this medication TXA, which is a medication that can prevent bleeding. So we did that. And then we did active management of the 3rd stage of labor, which basically means delivering the placenta as quickly as possible to avoid the risk of bleeding. Gave her Pitocin again to actively manage the 3rd stage after the delivery of infant, which helps the uterus clamp down to prevent bleeding. Methergin also given after placenta. And then the helicopter arrived with the platelets, and we loaded the patient onto the helicopter. She got her platelets en route and she did well. She was discharged from PSL a week later. So I think I'll stop there. And so we can just open it up for questions. I know I cruised through that kind of fast. It's a lot of information, but see anybody has anything.
Can you hear me, Dr. Paulson?
I can hear you.
We currently have no questions in the chat. Do we have any questions from the audience here? We technically have 10 minutes left if you want to cover another case.
Oh, okay.
There is one question that just came.
Okay. Yeah, let's.
What was the cause of the low platelets is the question.
Oh, yeah. So I'll keep going because I missed this part. Yeah. So the cause of the low platelets is HELP syndrome, which stands for hemolysis, elevated liver enzymes, and low platelets. This is considered to be a variant of preeclampsia and generally occurs during the third trimester or even after delivery. It's kind of a tricky situation because we don't always know exactly what causes it. And sometimes we just kind of find it incidentally. This particular patient actually was relatively well appearing and she felt fine, but she had this extremely dangerous complication of pregnancy. And so we were lucky to have found it.
Do we ever know what causes it though? Is it, why does some women have it and some not have it?
Well, I guess it's a good question. I think there are certain risk factors, but I don't know that we know exactly why some people get it. I think, obviously there are people that are at higher risk for preeclampsia. So people at risk for preeclampsia would be women at both ends of the age spectrum. So moms under the age of 20, over the age of 35, moms with diabetes, pre-existing hypertension, twins are at higher risk for that. Or even, family history of high blood pressure. But I think it's thought, typically to be like a placental, it's kind of a chicken and egg question, really. If it's the placental insufficiency causes the high blood pressure or vice versa, but it does have the potential for multiple organ failure if we don't catch it and treat it right away.
Thank you. We have another question that came in. Can a mother with low platelets then transfer that condition to her baby? We have a questioner who says that she had a platelet transfusion shortly after she was born, and would that be the reason why?
That's an interesting question. I would say that not directly. If mom had low platelets, baby wouldn't necessarily have low platelets. But if baby was born to a mom who had a complication of pregnancy, really any complication of pregnancy, that stress of delivery can cause low platelets in the baby. So anything like infection, or even potentially something like low blood sugar in the baby could cause low platelets. But I would say not directly, but sort of indirectly based on if baby was born early or sick due to complications that mom had.
Thank you very much. We have this question. Why did you choose this field of study, and what is the most difficult and rewarding part of this field?
Well, so I just love delivering babies and practicing family medicine and seeing these babies grow up, and just living really in parallel with all of these families. I feel like I was just kind of made to do this job. This is interesting because I was on a panel a couple of weeks ago where the same question came up, which what is the most difficult and rewarding thing, which is the same thing, which is taking care of my friends and neighbors, because it really is just very challenging to, care for care for the people that I really love. And it's hard to maintain boundaries. It's hard to watch the people that I really care for have health difficulties. But on the other side of the coin, when we have these amazing outcomes and beautiful families are grown, that's just so rewarding.
We have another question. What's a common misconception about births you wish people knew more about?
Oh gosh, that's a great question. I feel like that's a whole other talk. I think a common birth in America right now is a really interesting and controversial topic. I think, especially as it relates to rural medicine, I think that by and large, the doctors and the healthcare staff really do want the best for the patients. And I think, a lot of times people will think, oh, this person just had a C-section because, the doctor was in a hurry or whatever. But my group, especially after we have to do a C-section on somebody, especially for their first baby, we all sit around and we debrief that situation, and everybody just hates that we had to do that, because we always want the patient to have the best experience. And so I would say maybe a common misconception is that, doctors are burned out or just, in it for the money or whatever. And I think there is a lot of burnout, but I think in general, people really go into medicine and delivering babies because they love the challenge, and they love just the beauty of life in general. I have some rose-colored glasses, I think, too, but that would be one of the things I would say.
It was a nice answer. Thank you. We do have a question from our live audience.
Hello, my name is Clemmy, and I have a question. With DI twins, does that mean that they share the same placenta?
Oh, that's a great question. So typically they have two separate placentas. A lot of times the placentas they run out of room and they grow together, but yes, they have two separate placentas. There are some types of di twins that share a placenta, but by and large, they have their completely independent circulation.
Okay, we have a final question that we would be able to ask you, and I'm trying to find, here it is. How do you educate your students or potential students that going rural is a great opportunity to see a very unique side of healthcare? Many students can be hesitant if they're not already from those types of areas.
Yeah, I think that, so I love having students, and I love having students who are from rural areas and not from rural areas. I think that the best way that we teach our students is we get them involved in the community. So when I have the longitudinal students, I give them kind of a list of things that I want them to do. So one of them would be to go to the football games and stand on the sidelines with the physical therapists and the crew. Another thing that I've had students do is go and meet with hospice patients, go follow the hospice nurses. One of our wound care nurses used to do a service project where she would go to the senior center and trim toenails once every other week. And that sounds like kind of a funny thing to do, but it's actually pretty huge for our elderly population to have someone trim their toenails. It saves a lot of wounds. and is just a service for people. And the students just loved that because they would have an opportunity to sit and visit with the people in our community. So I think one of the best ways is for the students to have the opportunity to meet people in our community. And I think throughout their rotations, they usually have the opportunity to meet multiple families. So, and multiple members of the same family. So they'll deliver a baby and then they'll meet, the grandma of the baby in the clinic. And then they'll know all of the baby's siblings. And so I think that from the feedback that I've gotten from the students, that's been one of the best ways that they learn. But I also love when students come that aren't necessarily interested in rural medicine, or like we had a student just a couple months ago who came, I think she was from California, and she just said she wanted to challenge herself because she'd never had a rural experience before. And I was really proud of her because she wasn't going to go into rural medicine, but she had that experience. And I think she was able to advocate for us in where us as rural providers, wherever she goes, because she had that experience. And so that's another hope that I have for when the students come, is that they can learn all of the breadth of what we do, and that we really do have capability to do a lot of things in a rural area and a lot of things safely and well. And I think developing advocates is another interest that I have, in addition to enticing people to come practice rural medicine.
Thank you. Let's see if you can do this one in a minute. Are midwives and doulas much more common in rural areas since there is such scarce medical help for some, and what problems might that pose?
Yeah, so that's an interesting question. I'm sad I only have 1 minute. We I could give a whole other talk on that. We have some lay midwives that come from Kansas. That is a real difficult situation, but I've learned a lot from those midwives and how they practice. I don't know that they practice entirely legally exactly. But they do also serve as doulas, and they'll come into the hospital. And I do learn a lot from that. But one thing I'm really interested in is, and we're talking about doing this in our hospital, is hiring people that work, that are lay people in the community, specifically Spanish speaking people in our community that could serve as doulas to help the patients through their labors, that kind of work as a member of our team, but also our patient advocates. And so that's one of the projects that we're working on and hoping to have. And so I think that, but I would say what Dr. Deutschman would say is that increasing the number of family doctors is probably the key to providing obstetrical services that are safe and accessible, as opposed to adding midwives. Although there certainly could be a role for a midwife in a practice like ours, like a nurse midwife delivering in the hospital. So anyway, just to keep it short, but.
No, appreciate it. We really appreciate your perspective today. And we learned a lot. Thank you very, very much.
Thank you for asking me.